Okay, so it is 7:30, so it's time to kick off our film reading session for November. For those of you who haven't joined us before, we'll just do a very brief introduction. My name is Ian, and I'm a radiologist. I graduated from the RVC way back in 2004. I got my RCVS certificate in diagnostic imaging in 2009 before returning to the RVC in 2013 to do a residency in diagnostic imaging, and I got my European diploma back in 2018, which is a couple of years ago now. These days, you can find me at London Veterinary Specialists, which is the only multidisciplinary referral hospital in central London. And if I can help you at all with anything imaging related, if you'd like to have a chat about which imaging modality might be most appropriate for one of your patients, or if you would just like to go through some radiographs together, then you can drop me a line via email, or give me a call at the clinic on this number. So for these sessions, we like to just run through an example before we start and open up the floor to you guys. And this is an example taken from last month's session. It's a 4-month-old male entire Doberman that's presented as coughing. And we've got 2 radiographs, not the best quality radiograph. We'll start with the lateral view. So in this lateral view, it's probably a right lateral view, although we don't have a right-left marker here to help us out. But it looks like the caudal vena cava terminates at the cranial crus of the diaphragm. Also, the crura of the diaphragm look parallel rather than tapering to a point and looking like an L. And it looks like there's gas in the lumen of the gastric fundus rather than the pylorus. Now, there's lots going on in this radiograph. The most significant change is this increase in opacity between the caudal border of the cardiac silhouette and the margins of the diaphragm. And because of that increase in opacity, we've got some effacement of the caudal border of the cardiac silhouette, and we've got some effacement of the margins of the diaphragm as well. Creates the impression that there could be something poking through into the caudal thorax from the cranial abdomen. But if we take a peek at the cranial abdomen, we can see the margins of the liver, and that looks like it's in an appropriate location. And as I mentioned previously, we can see some gas within the lumen of the gastric fundus, which is also in a normal location. There are a few other changes here as well. In the cranioventral thorax, it looks like there's a tiny little fissure line between what's most likely to be the right cranial and right middle lung lobes. Although it's difficult to say, we'll take a look at the DV to get a little bit more information on that. There's also just a little increase in opacity in the cranioventral thorax as well, just also to the sternum. But the main thing I want you guys to concentrate on is this increase in opacity just here between the heart and the margins of the diaphragm. So if we look at the DV view, which again isn't the best quality radiograph, we can't really see the cardiac silhouette, so we should be able to pick up the heart just in the center of the thorax here, with the apex just positioned within that left caudal thorax. And it's really tricky to see. We maybe just get the impression that we can see the cranial borders of the cardiac silhouette, but caudally it's pretty tough to make out. And that's as a result of the same increase in opacity that we picked up in the lateral radiograph, just caudal to the heart, between the heart and the margins of the diaphragm. And just in that lateral view, we're not able to see the margins of the cardiac silhouette caudally. We're not able to see the margins of the diaphragm caudally either. So we've got this increase in opacity, again, between the heart and the diaphragm. We've got associated effacement of the margins of the cardiac silhouette and the margins of the diaphragm. And if we take a look a little bit more cranially, we're suspicious that there might be some fissure lines in the lateral view. We can see that on the right here, so between the right cranial and the right middle lung lobe, there's a little fissure line, and potentially between the left cranial and the left caudal lung lobe, there's also just a suggestion there could be a little fissure line. So in summary, what we've got is an increase in opacity. It's a heavy interstitial pattern. I wouldn't go so far as to say it was an alveolar pattern, because I'm not convinced I can see any bronchograms on this radiograph between the heart and the diaphragm in the region of the accessory lung lobe. So in the DV radiograph, the accessory lung lobe is quite tricky to see. It's usually a little easy to see on a VD rather than DV, but it sits in this kind of area. So it's just caudal to the heart and just cranial to the diaphragm, which corresponds to this sort of area here in the lateral view. So we've got a heavy increase in interstitial opacity, which has a ventral distribution in this lateral view. So if you guys just look at the dorsal part of the thorax, you can see it looks relatively normal. If you look at the ventral part of the thorax, then it's this ventral part here between the heart and the diaphragm that's affected. So the changes here, this heavy interstitial infiltrate that has a ventral distribution. So heavy interstitial infiltrate, which looks like it's just confined to the accessory lung lobe, which has a ventral distribution. The fact that the distribution of the change here is ventral, looking at this lateral radiograph, would suggest that this is likely to be a pneumonia rather than, say, an edema. So pulmonary edema, you're much more likely to get infiltrate and an increase in opacity in the hilar and the dorsocaudal thorax, particularly in dogs. And because of the distribution of the change here, it looks like it's a lobar. So we're not really seeing any changes to any of the other lung lobes, just the accessory lung lobe. So our suspicion should be that this patient could have an accessory lobar pneumonia. The other changes we can see, so the fissure lines, and also some of the effacement of the margins of the normal thoracic structures, like the heart and the diaphragm, that could be down to just a small volume pleural effusion here. And if this patient does have accessory lung lobe pneumonia, which is what we suspect, there could be an associated small volume pleural effusion. So this could be a pleural leak. If you were here last month, then you would have seen the CT scan that accompanied this patient. I won't go through that again tonight, because that was nicely wrapped up last time. But essentially, with the CT, we confirmed the suspicion of an accessory lobar pneumonia in this patient. And that's what it turned out to have. So for those of you who are here, any questions at all about our example? If there aren't, then we can move on to case number 1, which is a 2-year-old female entire Gordon setter that has an intermittent cough. So we've got a right lateral thoracic radiograph. We've got a dorsoventral radiograph. We have a left lateral of the thorax, and then just for fun, we've got a VD of the thorax as well. I know that there aren't too many of you guys joining me this evening. We've got Nikos, and we've got Luke, who is a constant. So Nikos, do you fancy taking us through case number 1?
Hello, good evening. Yeah, I can try my best, even though I'm not great, but I will try my best.
Yeah, go for it.
So yeah, we've got basically immature musculoskeletal dog. We've got the lateral DV and left lateral VD, as you said.
Yeah.
We've got now the right lateral. Let's see what I can find here. So there is basically maybe an increased opacity, kind of cranial, with a bit of cranially to that. I don't know if there's basically like in the beginning of the sternum here, maybe, yeah.
Okay.
And to me, I don't know if it's basically a bit more lucent, caudally to that. It's quite lucent, it's quite dark. So I can't even see, barely I can see a vasculature or anything like that, to be honest.
Okay.
I'm not sure if also the tracheobronchial lymph nodes there and in the trachea and the base of the heart. Not the, yeah.
So
yeah.
lymph nodes would be.
Yeah. Okay, fine. So yeah, I don't I don't see other than that anything. Skeletally seems to be okay.
Yeah.
No, the skeletally seems to be fine and normal, and the trachea seems to be all right. I don't think there's anything else I can probably pinpoint there.
No worries.
Yeah, I think so. If we just go for the next one.
Yeah.
Okay. So with this one, interesting. There might be on the. But then basically I'm saying things. Maybe on the left side of the thorax, where there may be the caudal, the middle, the cranial to the caudal lung lobe of the left one. There's maybe again an increased opacity.
This thing here.
In that area, yeah.
Yeah.
I can actually pinpoint. That's I'm a bit suspicious about. Nothing else really on that aspect.
Okay.
I know this too much opacity like in the middle, but I think that's probably, I don't know if it's the settings or whatever, but yeah, that's the only thing I can think of pinpoint here. Maybe.
Yeah, no worries.
Now the left lateral, okay, nothing. I don't know if I'm seeing anything here. I don't know if it's the lung from the the coronal part. This is a bit slightly elevated. I don't know if it's just me. Yeah, I'm not sure if it's just me or I would have maybe put a question mark there.
Okay.
But nothing else. I would just, anything screams to me here.
Yeah, no, I think that's absolutely fine. So we got one more. So the reason why I included the VD is
the VD.
That, yeah, we don't often see both DV and VD views for the same patient. For whatever reason, the vet that submitted these radiographs decided to do both. Not unreasonable. So the DV and the VD give you slightly different things. So I'd routinely do a DV. I think with a DV projection, you get a nicer view of the pulmonary vessels, particularly the caudal lobar pulmonary vessels. So I do DVs routinely. A VD will give you a better view of the accessory lung lobe, which is just here, which is relevant given the example that we've looked at this evening. Not to say that there's necessarily anything going on with the accessory lung lobe in this patient, but that would be a good reason to do a VD view over a DV. So if you are suspicious of something like pneumonia that might be affecting the accessory lung lobe, then something like a VD view might be useful. So this is our last view for this talk.
Yeah, I think that's it. Sorry, as a wrapping up.
Yeah. Okay. So what are you going to conclude for this little doggy, this 2-year-old setter coughing?
Yeah. To be honest, I'm completely clueless. So because we've got like increased lucency, it could be like I don't think it's the pneumothorax here or pneumomediastinum, not really. You're thinking as the lucency and increased lucency, but it's too much dark going on around there, which is basically air.
Yeah. So let's just pick up on that for a second. Pneumothorax, pneumomediastinum. So one of the things that we'd expect to see with pneumothorax is elevation of the cardiac silhouette from the sternum. So that's a really classic radiographic feature of pneumothorax. And I agree that the cranio-ventral thorax here looks a little strange, and we can talk about what that might be in just a moment. But for pneumothorax, we'd really expect to see some elevation of the cardiac silhouette from the sternum. And within the gap between the cardiac silhouette and the sternum, we shouldn't be able to see any pulmonary architecture. So we shouldn't be able to see any vessels, any bronchi, anything to suggest it's pulmonary tissue, because effectively it's gas. And we're seeing that gap because the cardiac silhouette is falling away from us towards the dependent part of the thorax. We'd also expect to see some retraction of the pulmonary parenchyma from the thoracic wall. And I kind of agree that here we're just wondering whether, well, is this gas here, and is this the edge of a lung? But if that was gas and we were seeing retraction of the left caudal lung lobe from the thoracic wall, then we'd expect to see the edges of that lung lobe, that left caudal lung lobe, from the lateral view. And we're not really seeing anything in this lateral view compatible with retraction of the pulmonary parenchyma from the thoracic wall and a partially collapsed left caudal lung lobe as a result of gas within the pleural space. I think what's happening here is because this is a very deep-chested dog and the exposures are not ideal. What we're seeing is just the edge of some soft tissues here. These are probably the pectoral muscles here that are making this area look a little bit more radiopaque than the more peripheral thorax. And I agree that it's kind of tricky to see the pulmonary architecture here because of the exposure, but I think you can see if you look. So I'm not convinced that this doggy has got a pneumothorax. This area here, this is the cranial mediastinal reflection here, and that's caused by the tips of the cranial lung lobes overlapping. So here the left lung is actually really nicely inflated relative to the right lung. So if you compare the size and the opacity of the left lung versus the right lung here, you can see that the left lung is bigger and it's more radiolucent compared to the right lung, which is a little bit smaller and a little bit more opaque. So I suspect that the vet who took these radiographs probably did a right lateral before doing this DV, which is why we've got a little bit of positional atelectasis of the right lung relative to the left, and the right lung is a little bit collapsed relative to the left. This cranial mediastinal reflection here is because we're seeing the tip of the left cranial lung lobe just overlapping the tip of the right cranial lung lobe. So this is probably the tip of the left cranial, and it's just overlapping the right cranial, and it's creating that little margin there, which is the cranial mediastinal reflection. So that, I think, is nothing for us to worry about. I think that's just a reflection, and it's caused by the left lung being more inflated than the right lung. If this doggy had a pneumomediastinum, then we'd expect to see some gas adjacent to the trachea. So typically you see gas just bordering the ventral border of the trachea. And if you have enough gas within the mediastinum, then you're going to start to see structures that you wouldn't normally see, like the brachycephalic trunk and the subclavian vein. Now, we're not really seeing that here either. So I think a mediastinum is pretty unlikely. So that covers these structures in the cranioventral thorax, and it covers a few other bits and pieces that you mentioned. I was interested that you brought this little area up here, which I agree is a little bit of a worry. So we've got a focal area of increased opacity within the left caudal thorax. It looks like it's almost bordering the left cranial and the left caudal lung lobe. And my suspicion is it's probably in the caudal part of the left cranial lung lobe. And given that this left lung, so the left cranial and left caudal lung, is pretty inflated, because the rest of it looks nicely lucent, it's difficult to explain why we've got this focal area of increased opacity in the caudal part of the left cranial lung lobe. So the thing to do is to go back to the lateral views and see if we can see anything in those lateral views that might explain that focal area of increased opacity. And if we want to evaluate the left lung, then the best view to look at is going to be the right lateral view, which is this view here. And what I want to draw your attention to is just this area here in the right lateral view. So we've got a little area of increased opacity superimposed over the cardiac silhouette in this right lateral view. And if you look closely, you can see that there are a few little radiolucent branching structures. And we can use the word arborizing here to describe the fact that they're branching superimposed over the cardiac silhouette. And my suspicion is that these little structures here are probably bronchograms. And if they are bronchograms, and that's our suspicion, then it means that there's some consolidation of that lung lobe. We can't tell which lung lobe it is just based on this right lateral view, but in this DV view, we have a suspicion that it could be the caudal part of the left cranial lobe. And again, if we wanted to describe the distribution of these changes, having isolated which lobe we feel is affected, so the caudal part of the left cranial, the changes here are very ventral. So if you sort of draw a line at the level of the caudal vena cava and you look at the dorsal part of the thorax here, that all looks pretty normal. You go ventral to it, that's when you start to see these changes. So we've got some air bronchograms superimposed over the cardiac silhouette in this right lateral view. They have a ventral distribution, and in the DV view, they're located in the caudal part of the left thorax, most likely within the caudal part of the left cranial lumbar. So we can put all that together. You can't really see it in DV. And say, well, our suspicion is that it could be that this dog has a pneumonia because of the ventral distribution of the infiltrate here affecting the caudal part of the left cranial. And that was the conclusion here, was that this patient had a very subtle lobar pneumonia affecting the caudal part of the left cranial. But yeah, nice job. So it's great that you pointed out a lot of these features because it gives me an opportunity to talk about what this little linear opacity is here, what a pneumothorax looks like, what a pneumodiastinium looks like, with the tracheobronchial lymph nodes are, etc., etc. So yeah, nice job. All right, anybody have any questions about case number 1? Are you happy with that, Nikos?
Yes, that's brilliant. Thank you so much for the insight. Cheers. Thank you.
All right. So if nobody has any questions about case number 1, then we'll move on to case number 2. Which is a 1-year-old female neutered domestic short-hair cat that is presented as vomiting. We have a right lateral view, and we have a dorsiventral view. That's all we have. So I'm not going to ask Nikos to present case number 2 because, I mean, essentially Nikos is off the hook having presented a case already. So we've got 2 other suspects, 2 other potential reporters. So we've got Rosa, who's joined us, and we've got Luke. Do either of you guys fancy taking me through case number 2 in terms of what you think might be going on? If not, I can run you through it myself.
I can try.
Yeah, brilliant. Thanks, Rosa.
Okay, so we have right lateral and a dorsoventral view of a skeletally mature cat, of caudal thorax in the abdomen, almost a catogram. The abdomen has got a good definition, and I can in both views, so I can see both kidneys, the bladder, which is pretty much caudal. I can see feces in the colon and in the rectum. And I can see that the small intestine is bunched and caudally displaced. And in the stomach, there is distended with air, and on the lateral view, it looks to me almost like a reverse C that you have with the dog with the torsion.
Okay.
And I can see ventral to it a round opacity, which should be the pylorus.
Yeah.
And it looks enlarged to me for a cat. And the liver is extending beyond the costal arch. Okay. I think on the DV I can see the tail of the spleen here, I think.
So you got the head of the spleen is just here.
Yeah.
And it's going to sort of wrap around here. It's tricky to pick that up.
Yeah. And again, I can see a stomach very distended.
Yeah.
And the intestine is bunched and displaced caudally. Plus, there is an enlarged loop that could be the duodenum. It's difficult to know. It's
I mean, there's this sort of structure here. There's also just a loop here that looks a bit chunky.
Yes. So this is what I see, basically.
Yep.
And my main suspicion, given the 2 different population of loops and the stomach distended, and I think that there is very likely a foreign body, or anyway an obstruction.
Yeah.
The cat is young, so foreign body is more likely than any sinister findings. So my recommendation would be, if they can afford, they can go for some imaging, but otherwise I would go for an X-lap, I think.
Yeah, no, I think that is a really good suggestion, and I absolutely agree with all of your findings there. Any of you guys have anything else to add? So Luke or Nikos, you agree with Rosa, or do you think there might be something else going on, or would you be a little bit more cautious? Or are we all thinking that this cat needs an X-lap and you should tell your nurses to start getting theatre ready?
I would go probably, yeah, agreed with Rosa, to be honest. I would be quite concerned about, yeah, all that. So, yeah.
Yeah, no, and I absolutely agree with you guys. And yeah, really liked your description, Rosa. Particularly liked the fact that you picked up on there are two distinct populations of what's most likely small bowel here. So we've got this big bunch of small bowel, which is a little bit caudally displaced. And then we've got a couple of loops of bowel here that are much bigger. So we've got a big loop of bowel within the mid-abdomen ventrally, and that's got a soft tissue opacity and more dorsally a gas opacity. And the question really is, do we think that that bit of bowel is small intestine or large intestine? Because if it's large intestine, we don't necessarily need to worry too much about it. But if it is small intestine, then it means there are two distinct populations of small bowel, one being considerably bigger than the other, and that would fit with an obstruction with a mechanical ileus. And if we look at the DV view, we can see that the colon starts on the left here and it extends cranially, and then as we get to the transverse colon, it moves from the left over to the right. We get ascending colon. This is probably cecum here. So we can see all of the large bowel here, and none of that is part of these dilated loops of bowel that we can see in both the lateral view and in the DV view. And not only that, as Moses pointed out, this stomach is pretty huge. So we've got a big old stomach. It's got a whole bunch of gas in it and opaque material, which is probably fluid. So the combination of two distinct populations of what we are reasonably confident are small bowel, one being dilated, and a stomach that is filled with gas and soft tissue opaque, likely fluid material, makes a mechanical ileus secondary to a foreign body really likely. This gas distribution within the stomach is a little bit strange, given that this is labeled as a right lateral view. I question whether or not it actually is. So I just wonder whether or not we've got part of the cava just passing through the diaphragmatic crura here, and the crura is certainly tapered to a point here, which would fit more the left lateral. And my suspicion is that this is gas within the antrum, and then the duodenum, which you're more likely to see in a left lateral rather than a right lateral. So I wonder whether this might have been mislabeled, which is making things a little bit more confusing. Doesn't take away from your description of the stomach. It is big, it is full of fluid and gas, and that is very worrying. So I absolutely agree. It's very likely that this patient has a foreign body, even though we can't specifically see the foreign body in these radiographs, and a mechanical ileus and a gastric dilation. I think the other thing that I always look at in these sorts of catagram or sort of dogogram radiographs where you're suspicious that there's significant abdominal pathology and the patient has been vomiting or regurgitating, and just taking a look at the thorax that's included, just to make sure there's no evidence of an aspiration pneumonia. So typically aspiration pneumonia, it's going to be ventral, it's going to be in the sort of right middle lung lobe typically, so it's going to be superimposed with the cardiac silhouette. So always worth having a look at this area, make sure you can't see any bronchograms, and also make sure that there's no evidence that there could be something sneaky like a concurrent esophageal foreign body. So we're worth having a look at the nosocomial thorax as well. Make sure there's nothing there to suggest to you there's anything stuck in the esophagus, and this patient might need something over and above an XLAP and removal of what you suspect to be a small intestinal foreign body. So yeah, absolutely agree. So what happened here is the patient did have an ultrasound, and this is the structure that I could see in its small bowel. So difficult really to get a good impression of what's going on here. So this is the wall of the small bowel here, and this is a big shadowing structure within the lumen of the small bowel at the level of the jejunum. So this is me following the bowel ORAD, so towards the patient's mouth effectively, so towards oral, and we can see this is just the edge of the foreign structure that I can see here, and ORAD to it, we've got this big dilated loop of small bowel, and then aborad to it, so this is me going in the other direction, following the intestine away from the mouth. This again is just the aborad edge of that foreign body. We can see that the bowel is completely empty. So that absolutely nails it on as a small intestinal foreign body and a mechanical ileus. The foreign body part being because this structure it's large, it's hypoechoic, it's shadowing. So you can see just how heavily shadowing the structure is here, but we're not really getting any ultrasound returning from the far field relative to this structure. And we've got dilation of the small bowel ORAD to it, and we've got empty small bowel aborad to it. So definite foreign body and definite mechanical ileus. So the large shadowing structure gives us our foreign body. The disparity between the ORAD and the aborad intestinal loops, the ORAD being very dilated, the aborad being completely empty, gives us our mechanical ileus. So yeah, Rosa was absolutely spot on. This cat did indeed have mechanical ileus and a foreign body, and XLAP was absolutely the recommendation. So if you guys had kept this cat without the benefit of the abdominal ultrasound, I think it would have been absolutely justified and completely reasonable. So yeah, nice job. Anybody have any questions about case number 2? I think you guys pretty much knocked that one out of the park. So this is case number 3. So this is a little bit different. So this is our first orthopedic case of the evening. So it's a young male neutered golden retriever, has an intermittent left forelimb lameness. And what we've got is a mediolateral, and we've got a craniocaudal view of the left elbow. We don't have the contralateral limb, unfortunately, to compare it to, just orthogonal views of the left elbow. So both you guys have presented a case now. I don't know if you fancy having a crack at this, Luke, or I potentially could run through this one, and then we can maybe do a potluck for the last case. Or unless any of you guys have a burning desire.
Again?
Yeah, go for it. Go for it.
There's no problem. There's just 2 of us.
Yeah.
So we have a mediolateral and a craniocaudal view of the left elbow of a skeletally mature dog, and I think the mediolateral one looks overexposed to me.
Yeah, I agree.
It's a bit dark. Anyway, what I can see here is some subchondral bone sclerosis of the radial head and also adjacent to the ulnar notch.
Yeah.
And also the margins of the medial coronoid process are quite fuzzy, quite indistinct.
Yeah, so the medial coronoid is going to be about here, and I agree, it's pretty difficult to see it.
On the craniocaudal, the only thing I can see really is a sort of very small area of radiolucency, which may not mean anything.
Where are we looking? Was we looking kind of here?
Yes.
Yeah. Okay. Yeah.
I don't know if it's relevant or if it's just positioning or.
Yeah, I mean, I think that might just be just the end osteal margin of the ulna that's just superimposed on that human condyle.
Yeah, and And then maybe medially, there is some bone deposition on the humeral condyle.
It's kind of here.
There,
Yeah.
That's it really.
Okay.
So I would say this is some early osteoarthritis with probably underlying elbow dysplasia, like fragmented coronoid process or something like that.
Yeah.
So I would recommend a CT scan.
Yeah, absolutely. No, I totally agree. So yeah, I think you've done super well with these radiographs. You're absolutely right that there absolutely is some sclerosis of this trochlear notch here. There are a few other very subtle changes. You're suspicious of there being some osteophytes on the medial aspect of this humeral condyle too, which would be a predilection site for osteophytes if there is just a very early osteoarthritis here. You'd also maybe expect them on the cranial surface of the proximal radius here, maybe the ankylosing process, maybe the medial coronoid process here, but they all look pretty clean. The articular margins look okay, and the humeral condyle itself looks fine as well. There's nothing to suggest there's anything going on there. So yeah, something like a medial coronoid disease, I think, would be top of the differential list here, and I think a CT would be entirely appropriate. So before we take a look at the CT, do you guys have anything else to add, or do you have any other questions about these radiographs? If not, we will move on. We'll take a look at the CT. So this is the same dog, and this is the CT. So I'm just going to let it run. I'm going to just move it on, and until we get to the left elbow, essentially. So we're going to stop it just there. So this is our left elbow. This is the one you're interested in, and the one we've just been looking at the radiographs of. This is our right elbow. So immediately, you guys can hopefully see, if we look at the medial coronoid, which is this structure just here, not only does it look quite sclerotic, so this medial coronoid is very hyper attenuating, and subjectively the medullary cavity is small. It's certainly smaller on the left than it is on the right, although I suspect there is a degree of sclerosis there too. Hopefully you guys can see that there's a dorsal linear fissure bisecting the base of this medial coronoid. And not only do we have a dorsal fissure, there are at least two very subtle sagittal fissures just bisecting the fragment that's making up the tip of that medial coronoid. So this dog, as Rosa predicted, does absolutely have medial coronoid disease. And not only that, it also has several fissures bisecting its medial coronoid. And one of the reasons why I wanted to show you guys these radiographs of the CT is it's, I think, pretty interesting to look at from how minor and subtle the changes can be on radiographs relative to how dramatic the changes can look on CT. So we could see that there was some evidence of medial coronoid disease on the radiographs, but the only changes that we could really make out were the sclerosis of the trochlear notch and the slight effacement of the margins of the medial coronoid in the medial-lateral view as a result of that sclerosis. We couldn't really see any discrete fragments in the craniocaudal view, and we couldn't see any fissures in either the medial-lateral or the craniocaudal view, but the CT shows it up really nicely. So there's a few other bits and bobs here that it's worth mentioning. So if we just go distal a little bit, hopefully you guys can appreciate just how irregular the margins of this trochlear notch are. So they should be nice and smooth, but they're pretty bumpy. Just there. I'll get my laser pointer and point that out. So I'm just looking at this area here. So we've got very irregular margins to that trochlear notch. And let's see if we can make out some osteophytes. So there is, in fact, a tiny little osteophyte on the cranial surface of that proximal radius, just there. Difficult to see that in the radiographs, but there it is on the CT. Now, Rosa picked up on some osteophytes on the medial aspect of the humeral condyle, and I think she's absolutely right. I think we can see some small osteophytes just here, which we wouldn't expect to see. So there certainly are some changes here compatible with an early or mild osteoarthritis as a result of this medial coronoid disease. I'm not convinced that there are really too many osteophytes on the medial coronoid or the anconeal process, which is the anconeus is just there. This is the anconeal process here. But there certainly are a couple of little osteophytes. Now, the other really subtle little change here is if we take a really careful look at the medial aspect of this humeral condyle, just kind of there. And if you guys, I can convince you guys that there's just a really subtle little lucidity there, a really subtle focal hypoattenuating area within the subchondral bone of the medial aspect of that humeral condyle. That could be just a really mild little OCD lesion as well. So that would be a predilection site for OCD in the elbow. And the fact that we're not seeing it on the right side, and it's completely adjacent to the fragmented coronoid that we're seeing, just makes me think that could just be a really early, really subtle little OCD lesion. So I thought this was kind of fun because for me, the changes on the radiographs were reasonably subtle, but the changes on the CT are pretty dramatic. And with the CT as well, we get to have a look at the other elbow, so the right elbow, and we can compare the two. So this is the right elbow here. So the right elbow, I still think that this medial coronoid and this trochlear notch are a little bit sclerotic. That's more hyper attenuating than I'd expect it to be, and the medullary cavity is maybe a little bit smaller than I'd expect it to be. It's not really as pointy as I'd like, that medial coronoid, so it's quite rounded as well. So I don't think that right medial coronoid is normal either, but it's certainly nowhere near as severely affected as the left. So yeah, Rosa absolutely called that, said that this dog was going to have a fragmented medial coronoid and medial coronoid disease, and that was the cause of the sclerosis of that trochlear notch and a couple of small osteophytes that we could see on those radiographs. And she was absolutely right. So if we go back to the radiographs again, just to convince ourselves that there were some changes here, then yeah, this is the area that we can see that sclerosis. So if you look at how opaque this area is here relative to the rest of the medullary cavity of the ulna, it certainly increased the opacity there. And it's not as easy to see the normal trabecular bone detail there. So there certainly are some changes there. And that's what Rosa picked up. In terms of the other changes, I'm not sure we can see the little osteophyte that we picked up on the CT on the cranial surface of that proximal radius. And even though, as Rosa pointed out, there's some effacement of the margins of that medial coronoid, I certainly can't see a fissure there or any fragments. The medial coronoid is just here. And again, I don't see a fissure or any fragments there to make us, to convince us that there's fissure lines and there's fragments, and this patient has a fragmented medial coronoid and would benefit from arthroscopy. So I just thought this was a really nice case to demonstrate the benefit of elbow CT in these patients where you guys have picked up some subtle changes on elbow radiographs, but you think, you know what, there might be something else going on here. This might just be the tip of the iceberg in terms of this dog's elbow disease. Yeah, CT super helpful. Lets us have a really good look at the elbows, at the medial coronoid, at the trochlear notch, the humeral condyle, and all of those predilection sites for osteophytes. So the cranial surface of the proximal radius, the anconeal process, the medial coronoid, and the humeral condyle. So yeah, I think it was kind of a nice case. Anybody have any questions about number 3, which was the orthopedic case of the evening? In which case we can move on to number 4, which, unlike all of our previous patients, who were all very young, this is now a very old, 16-year-old, in fact, male neutered Russian blue cat, has pretty non-specific clinical signs. So just presents to you with a little bit of weight loss. Okay, so we've got a right lateral, sort of catogram really, Then we've got, I think this is probably a VD catagram, or a left lateral catagram. Okay, so I guess I'll just open it up and see if any of you guys fancy taking me through case number 4.
I can take
go for it.
We'll try
Great.
my best, but
No, I think
it's
that's
not gonna be great. But let's have fun. Let's have fun.
Yeah, I think it's kind of two cases each, so that's fair.
Kind of fair. That's fair play. So yeah, we've got basically a catogram with a right lateral and a DV and a left lateral. So starting with the abdomen of the right lateral, the serosal detail, I guess, is not great. You can't distinguish many organs, as you can see, maybe barely a little bit of a kidney, and vessel slightly, I don't know if it's the bladder there, like the caudal margin, maybe, yeah, that side. The liver is popping up, which is maybe again extending the costal arch again. There is a kind of like an opacity, maybe of the gallbladder area, which is quite opaque. There's a little tiny thing here.
Yeah.
And now, as the rest of the video, we can see feces and the large intestine with a bit of gas, but nothing else I would say that's screaming about. I can see, I don't know, this like, sorry, just a bit weird to me. There's little vessellate things here that's quite increased opacity, things that extending, yes. Haven't seen this before, so I don't know what that is, but it is weird. Thorax wise, I don't know if I have a major comment on that one. I think it's pretty clearish and okay to me. I hope so.
Yeah, no, I agree.
Now I don't know. Sorry, I don't know if the DV there's anything else to add. It is a little bit tilted, so we don't have like a straight back.
Yeah, it's true. Oblique.
There's gas in the stomach and the fundus. Again, there's some gas there. Could be really large intestine. And then there's basically things that's still coming up quite slightly. Again, on the liver part, kind of there on the right side.
Right, yeah.
But again, nothing that's popping up. Again, maybe you can see still that maybe the increased opacity, but there's still the gallbladder there, on more of the right side here, but probably that's kind of makes sense based on the right lateral. And then we have the left lateral right as well, yeah, I think, which is again, I see very, very similar things. I don't think there's anything else to add, to be honest, on those.
Yeah, no, that's fair enough. So what do you think these structures you've described are?
I mean, I guess with the gallbladder, that's basically higher in opacity. It could be maybe kind of like a gallbladder stone, similar to that.
Yeah.
And I'm not sure if like this little kind of like linear kind of like things, if it's anything like mineralized. That's something that it could be, which I know I've never seen this before, which is quite cool. But nothing else there. So I guess we're talking about a potential gallbladder stone, but I'm not sure if that's enough to cause all of this kind of like clinical sense for this elderly cat.
Yeah. Okay. No, I think that's absolutely fine, and yeah, I agree with all of your findings. I absolutely take your point that the serosal detail is a little bit poor in this cat, but it's a pretty skinny cat. And it's presented for weight loss. It really isn't very much subcutaneous fat at all. You can see that our spinous processes are creating little bumps along the dorsum. This is a pretty thin cat, and I think that's probably why we've got such poor serosal detail. I agree that there isn't really too much else to see other than what you've described. So we've got this focal mineralized structure, and it's within it's the right cranioventral abdomen, and you're absolutely right that that would be where we'd expect the gallbladder to be. And so that could absolutely represent a stone within the gallbladder, so a big cololith or a whole bunch of mineralized sediment within the gallbladder. So the opacity of the structure, as we've just said, is mineralized, and the opacity of this structure, which you said looked a little bit like a vessel, and I agree. It's branching, and again, we could use the word arborizing. I really like that word. It means branching. It looks like a vessel or a bronchus. It means it starts off wide and then it's letting off lots of branches like a tree, and that's what this structure is doing here as it's extending ventrally. We're seeing lots of little peripheral branches come off it. That thing has a mineralized opacity as well. So if we compare the opacity of this branching structure that's superimposed on the liver to the opacity of the focal structure that we believe represents some mineralized sediment or a stone within the gallbladder, they're kind of equivalent, really. And they're as opaque as the adjacent ribs, if not more opaque. So these are absolutely both mineralized structures. So we then need to think, well, how can we sort of link the two? Well, if this is a stone or if it's mineralized material within the lumen of the gallbladder, and given its location, we can be reasonably confident that this mineralized material is within the lumen of the gallbladder, then how can we link this structure here, which is that same branching structure we can see in the left lateral, to all this mineralized material? Well, if you had mineralized material in the intrahepatic bile ducts and you had enough of it, so it was dense enough, then that could create the appearance of almost a mineralized vessel within and superimposed on the liver on these radiographs. And that's what I think this is. I've never seen this before either, which is why I've included it. When this cat had an ultrasound scan, and unfortunately I had the ultrasound scan with its PCP, what the vet could see was linear hyperechoic shadowing structures within the liver. And I think what she was looking at was this mineralized material within the intrahepatic bile ducts. So I think what we're seeing here is a whole bunch of mineralized material within some of the intrahepatic bile ducts. We're seeing that same material within the lumen of the gallbladder. Now, there's nothing to say that these changes are responsible for this cat's weight loss. It could be that this cat has a chronic cholangitis or a chronic cholangiohepatitis that might be predisposing it to forming this mineralized sediment within its intrahepatic bile ducts and within its gallbladder. We can't see this cat's common bile duct here, and we don't have any information about this cat's biochemical parameters, so we don't know what this cat's total bilirubin is. So this cat having so much mineralized material within its intrahepatic bile ducts and within its gallbladder is certainly a cat that has a cholelithiasis, so is predisposed to developing an extrahepatic biliary obstruction. So something that I'd really like to do in this cat to make sure that it's not causing a problem, particularly if it has a raised total bilirubin, would be to look at the common bile duct. Just make sure that there's no evidence of an extrahepatic biliary obstruction, and that potentially is more likely to be causing the vague clinical signs as this cat is presented with, so the weight loss. So certainly an abdominal ultrasound would be indicated here. You can take a look at the gallbladder, see if there is a big stone there or just some sediment. Take a look at the rest of the hepatic parenchyma, see if you can see some mineralized, so hyperechoic shadowing material within the intrahepatic bile ducts, and take a good look at the common bile duct and the papilla to make sure that this cat doesn't have any evidence of an extrahepatic biliary obstruction, and then have a drive around the rest of the abdomen and make sure there's nothing else going on. But the reason why I included this is because I'm not sure I've ever seen mineralized branching structures superimposed over the liver. And like I say, I think the reason for that in this case is that this is just mineralized sediment within the intrahepatic bile ducts. And this, I think, is a pretty typical appearance for mineralized material within the gallbladder lumen, or potentially it could be a couple or one big cololith. So yeah, I thought I would share that with you. The reason why it's potentially difficult to see is because it's a little bit too ventral in the lateral view, but you could sort of look over it because it almost looks a bit like the extension of a rib. And in the VD view as well, you've got the ribs just next to it, and it kind of looks like it could just be a rib, so easy to miss. But no, you picked it up, you spotted it, and yeah, said that, you know what, this is probably a stone in the gallbladder, and yeah, just taking that forward and running with it. Well, if this is mineralized material and stone in the gallbladder, that's probably mineralized material within the intrahepatic bile ducts. Yeah, this cat could potentially have a chronic cholangitis or cholangiohepatitis. So yeah, maybe needs an ultrasound. So yeah, nice job. All right. Any of you guys have anything to add to case number 3, or have any questions about, case number 4, have any questions about case number 4, or any of the cases that we've just run through this evening? No, you guys happy? So we had a kind of a nice mix, and some orthopedic films, and some thoracic films, and some abdominal films. So yeah, I hope you enjoyed it. If there are no other questions, then I shall let you guys get on and enjoy the remainder of your evening. And yeah, thank you very much for joining me this evening. I hope it was fun, and I hope you learned a little bit about radiographs. All right, thanks, Rosa.
Thank you so much.
Thanks, Nikos. Thanks, mate. Bye-bye.